Diving into neurology today, getting you prepped for rounds with some classic presentations and mechanisms. We've got a fantastic neurologist with us who can help break it all down.
Absolutely. Happy to be here. Yeah, it looks like we'll be covering a pretty broad range brain anatomy, those tricky brainstem syndromes, and even some less common cases down the line. Should be a good review.
Perfect. It's like a rapid fire neuro review. So
hmm
to set the stage, let's touch on some brain anatomy basics, just the areas that'll come up in these Q&As.
For sure, for sure. I think the brainstem's always a good place to start, right? It's chock full of vital structures and pathways, and understanding its anatomy is really key to deciphering all those brainstem syndromes.
Right. So breaking down the brainstem, we've got the midbrain at the top, then the pons, and then the medulla.
Exactly, exactly. And remember, the midbrain is where you find the superior colliculus plays a vital role in controlling upward gaze. That'll be important when we get to Paranose syndrome.
Ah, yes. Paranose syndrome, that classic upward gaze palsy. Can you remind me of the mechanism again?
So picture a pineal gland tumor. Now imagine that tumor pressing on the superior colliculus in the midbrain. That pressure disrupts the pathways responsible for upward eye movements, leading to the inability to look up. Think parano equals pineal problem in the midbrain, helps tie it all together.
Love that mnemonic.
Yeah.
It's all about location, location, location in neurology, especially with these brainstem syndromes. Speaking of which, let's move on to those. Our listener has a bunch of Q&As on lateral pontine, lateral medullary, or Wallenberg, and medial medullary syndromes.
Awesome. Let's tackle them one by one. Lateral pontine syndrome, also called Marie-Foix syndrome, is caused by a stroke affecting the anterior inferior cerebellar artery, the AICA. Think lateral pontine facial drop on the side helps you remember that ipsilateral facial weakness.
Right, that facial drop is a key feature. But it's not just facial weakness, right?
You got it, you got it. You'll also see things like decreased lacrimation, meaning reduced tear production and hearing loss on the same side as the lesion. Why? Because the ASCA also supplies structures involved in tearing and hearing. So if you see a patient with sudden facial weakness, dry eyes, and hearing loss all on the same side, think ASCA stroke and lateral pontine syndrome.
That's super helpful clinically.
Okay.
Now on to Wallenberg syndrome, or lateral medullary syndrome. What's the artery we need to know here?
So Wallenberg syndrome is usually caused by a stroke affecting the posterior inferior cerebellar artery, or PICA, and the real takeaway here is that it often presents with a mix of ipsilateral and contralateral symptoms.
Ah, yes, the one with the crossed findings.
Exactly. So the classic presentation: loss of pain and temperature sensation on the ipsilateral face, Horner syndrome, ptosis, meiosis, and anadrosis, dysphagia, and hoarseness.
So we've got cranial nerve and autonomic dysfunction all on the same side as the lesion. What about those contralateral findings?
Contralaterally, you'll see loss of pain and temperature sensation on the body, which is because the pathways for pain and temperature actually cross over in the spinal cord. And to help remember this one, think Wallenberg, walking imbalance, due to the ataxia that often comes along with the syndrome.
Walking imbalance, I like it. It's a good way to remember that it affects the cerebellum. Okay, now on to medial medullary syndrome. What's the key takeaway here?
So medial medullary syndrome typically results from a stroke affecting the anterior spinal artery. And the real hallmark of this syndrome is contralateral hemiparesis.
Weakness on the opposite side of the body from the lesion.
Exactly. You may also see ipsilateral tongue deviation, meaning the tongue deviates toward the side of the lesion. Think medial medulla, middle motor misery to remember those motor symptoms.
Perfect. Those mnemonics are so helpful for keeping those brainstem syndromes straight. Now, looks like our listener also had a couple of questions about different types of brain bleeds they're covering: epidural, subdural, subarachnoid, and intraparenchymal hemorrhages.
All right, great. Let's break them down systematically. Starting with epidural hematoma, it's really important to recognize this one quickly because it's a neurosurgical emergency.
Right, epidural emergency bleed. What causes this type of bleed?
So epidural hematomas usually result from a rupture of the middle meningeal artery, and that's often due to a skull fracture. The bleeding happens between the skull and the dura mater, that tough outer membrane surrounding the brain.
And what are the classic clinical features?
One of the hallmark signs is the lucid interval. So the patient might initially seem fine after the head injury, but then rapidly deteriorates as the hematoma expands and compresses the brain. You might also see a dilated pupil on the side of the lesion.
So a head injury followed by a lucid interval and then neurological decline, major red flag, even if that initial CT scan doesn't show anything.
Exactly, exactly. You got to have a high index of suspicion in these cases and consider a repeat CT scan if there's any clinical concern.
Okay, now on to subdural hematomas. How do these differ from epidurals?
So subdural hematomas, they involve bleeding between the dura mater and the arachnoid mater, another layer of the meninges. They usually result from a rupture of bridging veins, those delicate veins that connect the brain surface to the dural sinuses.
And subdural hematomas are often associated with head trauma, but they can also happen in older adults or people on blood thinners even after seemingly minor falls.
That's right. And unlike epidural hematomas, subdural bleeds tend to develop more slowly, sometimes over days or even weeks. They're often described as crescent-shaped on imaging, in contrast to the biconvex shape of epidural hematomas. The mnemonic subdural slow vein bleed can help you distinguish them.
Okay, that's helpful. Now, subarachnoid hemorrhage, I always associate this one with a very specific kind of headache.
Oh, absolutely. Subarachnoid hemorrhage, you get this sudden, intense headache, often described as the worst headache of my life.
Right, that classic thunderclap headache. What causes this type of bleed?
So it's caused by bleeding into the subarachnoid space, that area between the arachnoid mater and the pia mater, the innermost layer of the meninges. And the most common cause is a ruptured berry aneurysm, a weak, bulging spot on a blood vessel in the brain. To remember this association, think subarachnoid, sudden aneurysm bleed.
Makes sense. Finally, let's discuss intraparenchymal hemorrhage. That's bleeding within the brain tissue itself, right?
Right, and the most common cause of an intraparenchymal bleed is chronic hypertension. High blood pressure weakens the walls of small arteries in the brain, making them prone to rupture.
So it's something we see pretty frequently in patients with poorly controlled hypertension.
Exactly. The clinical presentation can vary depending on the location and size of the bleed. Patients might experience headache, focal neurological deficits like weakness or sensory loss, seizures, or altered mental status. Think intraparenchymal inside brain bleed to remember its location.
Okay, great. So we've covered those four main types of brain bleeds, each with its own distinct mechanism and clinical presentation. Now, our listener also wants to review some less common but equally fascinating neurological conditions.
Let's see what we've got.
First up, we have neonatal intraventricular hemorrhage. Looks like our listener wants to brush up on the specifics of this condition.
Yeah, neonatal intraventricular hemorrhage, or IVH for short, is a condition unique to premature infants. Remember, their tiny brains are still developing, and the blood vessels are especially fragile.
Right. So what exactly happens in neonatal IVH?
Well, in premature infants, the germinal matrix, a highly vascularized area in the brain where nerve cells are produced, is particularly susceptible to bleeding. This can lead to bleeding into the ventricles, those fluid-filled spaces within the brain.
And this can lead to all sorts of complications, right?
Absolutely. It can cause hydrocephalus, seizures, developmental delays, and even cerebral palsy. It's a condition that requires specialized care and monitoring in the NICU. Early detection and intervention are really key to minimizing long-term neurological damage.
Okay, that's a good overview of neonatal IVH. Now, how about phantom limb pain? This one always fascinated me.
It is a fascinating phenomenon. Phantom limb pain is when someone who's had a limb amputated still experiences pain sensations that seem to be coming from the missing limb.
It's like the brain still remembers the limb and sends pain signals, even though the limb isn't there anymore.
Exactly. It's thought to be due to reorganization of the somatosensory cortex, the part of the brain that processes sensory information from the body. After an amputation, the area of the somatosensory cortex that previously received input from the missing limb can become rewired and start responding to input from other body parts.
So it's like the brain is trying to make sense of the missing input and creates pain signals in the process. What's fascinating is that it highlights the incredible plasticity of the brain.
Right. The brain is constantly adapting and rewiring itself. In this case, unfortunately, that rewiring leads to pain. Phantom pain. Perception without limb. It's a good way to capture the essence of this phenomenon.
Okay, that's pretty mind-blowing. Last but not least, let's discuss diffuse axonal injury. I know this is a severe type of traumatic brain injury.
Diffuse axonal injury, or DAI, is a serious condition that occurs when the brain is subjected to rapid acceleration or deceleration forces, like in a car accident or a fall. These forces cause widespread stretching and tearing of axons, those long nerve fibers that connect different parts of the brain.
And I remember learning that even seemingly minor trauma can sometimes lead to DAI.
That's right. The severity of the external injury doesn't always correlate with the severity of the brain injury. It's all about the forces transmitted to the brain. Those shearing forces disrupt the delicate connections within the brain, leading to widespread damage that can result in coma or even a persistent vegetative state.
So even though there might not be a visible focal injury, the damage can be extensive and have significant functional consequences. What's a good way to remember the mechanism?
Diffuse axonal diffuse brain disruption, that kind of captures the essence of the widespread damage that occurs in DAI.
Great, so we've covered quite a bit of ground already. Brain anatomy, brain stem syndromes, brain bleeds, and some unique neurological cases. It's been a whirlwind of information.
It has, but I think we've laid a good foundation for understanding these key neurological concepts.
I agree. And I think those mnemonics will be a lifesaver for our listener when they're on rounds. But we're not done yet. We still have more to discuss, including language disorders and some clinical pearls to tie it all together.
All right, so let's keep this neuro review rolling. You're doing great with those mnemonics and key takeaways.
Thanks. They really help to keep it all straight. It's amazing how much is packed into these Q&As. So where to next?
Well, we've talked about recognizing different types of brain bleeds, but let's get a little more practical. How do we actually approach these bleeds in the clinic?
Great idea. So let's say a patient comes in with a suspected brain bleed. What are the first steps?
First and foremost, make sure their airway, breathing, and circulation are stable ABCs, right? Always comes first in an emergency.
Right, those are the fundamentals. Then what?
Then we need to get a detailed history and perform a thorough neurological exam. We want to know about any head trauma, risk factors like hypertension or bleeding disorders, and the timeline of their symptoms.
So gathering those crucial clues to help pinpoint the diagnosis.
Exactly. And while we're doing that, we order a CT scan of the head. That's our go-to imaging for evaluating suspected brain bleeds. It's fast, readily available, and gives us a clear picture of what's going on.
And the CT helps us differentiate between those different types of bleeds, right? We talked about the characteristic shapes like biconvex for epidural, crescent shape for subdural, and so on.
Absolutely. The location and appearance of the bleed on the CT, along with the clinical presentation, all help us put the pieces together and determine the most likely diagnosis.
Okay, so we've got the diagnosis. Now what? How do we actually manage these bleeds?
Well, the management really depends on several factors, including the type of bleed, the size, the location, and the patient's overall clinical status.
So it's a very individualized approach.
Right. But there are some general principles that apply across the board. We need to make sure to control blood pressure to prevent further bleeding, and we also need to monitor closely for signs of increased intracranial pressure, which can be life-threatening.
And what about surgery? When do we need to go in and evacuate a bleed?
Surgery is often necessary for large bleeds, or those that are causing significant mass effect, meaning they're putting pressure on vital brain structures, like a large epidural hematoma that often requires surgical evacuation to relieve that pressure.
So it's a delicate balance between managing the bleed conservatively and intervening surgically when necessary.
You got it. It's a real team effort involving neurologists, neurosurgeons, critical care specialists. We all work together to determine the best course of action for each patient.
Okay, now let's go back to those really interesting cases of phantom limb pain and diffuse axonal injury. Are there any new insights into how we manage these conditions?
Phantom limb pain, it's still a bit of a mystery, but we're learning more about the role of neuroplasticity and central sensitization. After an amputation, the brain undergoes this significant reorganization, and the areas of the somatosensory cortex that used to get input from the missing limb can become hyperexcitable.
So it's like the brain is trying to fill the void left by the missing limb, but then ends up creating pain in the process.
That's a good way to put it, yeah. And this central sensitization can actually be amplified by things happening in the periphery, like nerve damage or inflammation in the residual limb.
So it's a complex interplay of central and peripheral factors. Are there any effective treatments for phantom limb pain?
Well, unfortunately, there's no one-size-fits-all solution, but different treatments can help. We sometimes use medications like antidepressants, anticonvulsants, even opioids to try to modulate those pain signals.
And what about things we can do that don't involve medication?
Yeah, those are important too. Things like mirror therapy, biofeedback, and transcranial magnetic stimulation, they can all help to sort of retrain the brain and reduce pain perception.
So it's a multimodal approach, addressing both the physical and psychological aspects of pain.
Exactly. And this often involves a whole team: pain specialists, neurologists, psychologists, physical therapists.
Okay, that makes sense. Now, what about diffuse axonal injury? We know it involves widespread damage to those axons, but what are some of the specific mechanisms at play?
Diffuse axonal injury is a really complex process. Imagine these delicate axons being stretched and torn by the rapid acceleration or deceleration, This disruption impairs axonal transport, those essential processes that move nutrients and other molecules along the axon.
So it's like those crucial supply lines within the brain are being disrupted.
Precisely. And this leads to a cascade of secondary events: inflammation, excitotoxicity, oxidative stress, all of which contribute to neuronal death and dysfunction.
And sadly, there's no way to reverse this damage, right?
Unfortunately, no. Treatment for diffuse axonal injury focuses on supportive care, like managing intracranial pressure, controlling seizures, preventing things like pneumonia or blood clots.
So it's all about maximizing recovery and giving these patients the best quality of life possible.
Absolutely. And rehabilitation plays a crucial role in helping them regain function and adapt to their new limitations. Physical therapy, occupational therapy, speech therapy, cognitive rehabilitation, all of these can be beneficial.
Sounds like a true team effort is needed to manage these complex cases. Now let's shift gears and talk about language disorders, specifically aphasia. I know our listener had some questions about differentiating between the different types.
Okay, great. Aphasia can definitely be tricky. Let's start by going back to that mnemonic aphasia area affected, Wernicke or Broca.
Right. So if Wernicke's area is affected, we see receptive aphasia, and if Broca's area is affected, we see expressive aphasia. Can you remind me of those key clinical features?
Sure. With receptive aphasia, think word salad. Patients can speak fluently, but their speech is often meaningless, nonsensical, with jumbled words and made-up phrases. They also have trouble understanding what others are saying.
So fluent but nonsensical speech and impaired comprehension. What about expressive aphasia?
With expressive aphasia, think broken speech. They understand what others are saying, but they have trouble producing speech. It's often halting, effortful, with lots of pauses and grammatical errors. They may know what they want to say, but they just can't get the words out.
Okay, so receptive, fluent but nonsensical, expressive, broken speech. What about conduction aphasia? That one always trips me up a bit.
Conduction aphasia is interesting. It's caused by damage to the arcuate fasciculus, which is the connection between Wernicke's and Broca's areas. Think of it like a disruption in the pathway that allows us to repeat what we hear.
Ah, so that's why patients with conduction aphasia have difficulty repeating phrases, even though their speech is fairly fluent and their comprehension is good?
Exactly. They can understand what you're saying and they can speak pretty well, but they struggle to just parrot back what they hear. And often they're even aware of their errors and try to correct themselves.
Okay, makes sense. Conduction, communication line broken. That's helpful to visualize that disrupted connection. Now, what about global aphasia? What's the key takeaway there?
Global aphasia is the most severe form. It results from widespread damage to both Wernicke's and Broca's areas, as well as surrounding areas. You can almost think of it as a global disruption of those language networks in the brain.
So patients with global aphasia basically have severe impairments in both comprehension and production of language.
Exactly. Their speech is often limited to just a few words or phrases, and they really struggle to understand even simple spoken or written language.
Global aphasia, global language loss. Simple but effective. Okay, we've covered a lot with language disorders. What else should we touch on for our listeners' neuro prep?
Well, we've discussed those classic brainstem syndromes, lateral pontine, Wallenberg, medial medullary, but let's just do a quick recap and really hit on those key clinical features that help us tell them apart.
Perfect. Pattern recognition is key in neurology, so let's review those patterns one last time.
For sure. So for lateral pontine syndrome, remember facial drop on the side, looking for ipsilateral facial weakness, decreased lacrimation, and hearing loss.
Okay, good reminder. What about Wallenberg?
For Wallenberg, think walking imbalance and those crossed findings. You'll see ipsilateral loss of pain and temperature on the face, along with Horner syndrome, dysphagia, and hoarseness. And then contralaterally, loss of pain and temp on the body.
So it's a mix of cranial nerve, autonomic, and sensory findings, some ipsilateral, some contralateral.
Right.
What about medial medullary syndrome?
Medial medullary, remember, middle motor misery. The hallmark is contralateral hemiparesis, and you may see ipsilateral tongue deviation.
Perfect. Those mnemonics are so helpful for keeping them straight. I think we've covered a ton in this review session.
We have. But, it's all essential stuff for anyone working with neuro patients.
I agree. I think we've done a good job of breaking it down and highlighting those key clinical pearls.
Okay, I feel like we've already covered so much, but I'm sure there are still some fascinating areas to explore in this neurology review.
Oh, absolutely. This last section will really help solidify your understanding of how these neurological conditions actually present in real-life situations, clinical practice.
Perfect. So where to next on this neuro journey?
Well, we've talked about a bunch of specific conditions, but let's take a step back and think about some broader principles, some things that are helpful when approaching any neuro case.
Great idea. Connecting the dots, seeing the bigger picture. What are some of those overarching principles?
One key principle is localization. Remember, the nervous system is super organized. Different parts of the brain and spinal cord have very specific functions. So when someone comes in with neurological symptoms, our first job is figuring out where the problem is.
Right, like solving a puzzle which piece isn't working properly. Exactly, and we use all the clues we gather from the history, the physical exam, the imaging, to try to pinpoint that lesion.
So let's say a patient comes in with weakness on their right side. We can assume the problem is probably somewhere in the left hemisphere of the brain, since that controls movement on the right.
Perfect example. That's localization in action. Another important thing to consider is the time course of the illness.
Right, like whether it's a sudden stroke or a slowly progressive neurodegenerative disease. That tells us a lot about what might be going on.
Absolutely. Sudden onset, you got to think about things like a stroke, gradual progressive decline, maybe a neurodegenerative disorder, or a slowly growing tumor.
Okay, so localization and time course are two big ones. What else is important to keep in mind?
Always got to consider the patient's medical history, any relevant risk factors.
Right, like hypertension, diabetes, history of smoking, family history of neurological disorders, all those things.
Exactly. All of those can play a role and help guide our diagnosis and treatment plan.
Okay, those are some really good general principles to remember. Now let's get to those clinical correlations. How can we take all of this knowledge and actually apply it in the real world with real patients?
That's the goal, right? Taking those textbook concepts and seeing how they play out at the bedside. So let's walk through some hypothetical cases, focusing on those key symptoms, diagnostic clues, potential complications, and treatment approaches that you'll see during rounds.
Love it. Let's put on those neurology detective hats and see what we can figure out.
All right, case number one. We have a 65-year-old man with a history of hypertension. He comes to the ER with sudden onset weakness on his right side and difficulty speaking.
Okay, so we've got a patient with vascular risk factors presenting with acute neurological deficits. Sounds like a stroke to me. What's our first move?
You got a stroke is definitely top of the list, and
Okay.
time is brain right. We got a CT scan of the head, ASAP. We need to know, is this an ischemic stroke caused by a blockage? Or a hemorrhagic stroke caused by bleeding?
Right, and while we're waiting for the CT, we'll do a full neuro exam, pinpoint those deficits, and see if we can localize the lesion.
For sure, for sure. Based on those symptoms, right-sided weakness and speech problems, it's probably a left hemisphere stroke.
Okay, let's say the CT confirms an ischemic stroke. What's next?
We need to figure out if he's a candidate for thrombolytic therapy, that's the clot buster medication. It can dissolve the clot and restore blood flow, but it has to be given within a specific window.
Right. Every minute counts when it comes to minimizing brain damage.
Exactly. So we need to act fast and weigh those risks and benefits.
Okay, on to case number 2. We have a 25-year-old woman with a sudden, intense headache. She says it's the worst headache of her life.
Ooh, that presentation red flags for subarachnoid hemorrhage. Remember, that thunderclap headache is super classic.
Right. Subarachnoid equals sudden aneurysm bleed. What do we do?
Gotta rule that out quickly. First, get a CT of the head. If that's negative, but we're still really suspicious, we'll do a lumbar puncture and check the cerebrospinal fluid for blood.
And if the lumbar puncture shows a subarachnoid hemorrhage?
Then we need to find that source of bleeding, which is usually a ruptured berry aneurysm. Cerebral angiogram is the best way to see those blood vessels and identify the aneurysm.
Okay, so we've covered stroke and subarachnoid hemorrhage. What about a brain tumor case?
Good one. Let's say we have a 40-year-old patient. They've been having progressively worse headaches, especially in the mornings, and also some personality changes, difficulty concentrating.
Yeah, those are concerning. What are we thinking?
Could be a slow-growing brain tumor. Those headaches, especially if they're worse in the morning, might be a sign of increased pressure in the skull. And the personality changes and cognitive problems might mean the frontal lobes are involved, which control those executive functions.
So what will we do next?
Order a brain MRI. It's better than a CT scan at picking up brain tumors and other subtle things.
And if we do find a tumor, what then?
Well, how we manage a brain tumor really depends on a lot of things. The location, size, type, grade. Treatment might involve surgery, radiation, or chemo.
Okay, that's helpful to know. Now, before we finish up, I think it's worth going back over those mnemonics one last time. They're so useful for remembering these concepts.
Absolutely. Let's recap. Perinatal syndrome, pineal problem in the midbrain, lateral pontine, facial drop on the side, Wallenberg walking imbalance, remember those crossed findings,
Yeah.
medial medullary, medial medulla, middle motor misery, epidural hematoma, epidural emergency bleed, subdural hematoma, subdural slow vein bleed, subarachnoid hemorrhage, subarachnoid sudden aneurysm bleed, and finally, interparenchymal hemorrhage, intraparenchymal inside brain bleed.
Wow, I think I've got them all memorized now.
That's great. But remember, mnemonics are just a tool. It's important to really understand the anatomy, physiology, and what's going wrong to truly master neurology.
Well said. Neurology can be a tough subject, but it's so rewarding. Like you said, it's like solving a puzzle, putting all the pieces together to get the diagnosis, and then figuring out how to best help our patients.
Couldn't agree more. Working with the brain, the most complex organ in the body, it's truly a privilege.
Well, I think we've covered everything we planned for this neuro deep dive. Brain anatomy, the classic syndromes, the different brain bleeds, some really unique cases, plus diagnostic approaches, treatments, and clinical pearls.
We did it. I hope this has given you a good foundation for your neurology rotations.
I definitely feel more prepared, thanks to you. Any last words of advice for our listeners as they start their neurology journey?
Just remember, neurology is constantly evolving. There are new discoveries happening all the time, so stay curious, keep learning, and never be afraid to ask questions.
I love that advice. Stay curious, keep learning, keep asking questions. Great advice for life in general, not just neurology. Well, I think it's time to wrap up this deep dive. It's been a pleasure chatting about neurology with you.
The pleasure was all mine. And best of luck on your neuro rounds. You've got this.
And to all of you listening out there, thank you so much for joining us on this deep dive. We hope you found it informative and helpful. Until next time, keep those brains buzzing.